So, hello again. Dear Marisa, dear Jesus, really pleased again to speak about this important subject here in this Congress. And I have to say it has been quite refreshing preparing a talk which was not on before and after photos, but really on complications and all the things we don't want to see and not the things which we plastic surgeons normally would like to see. It's not working, doesn't matter. I've got no disclosures regarding this talk. I want to give you a review on a 10-year experience which I do or have done in my own private practice surgical center. I run a private practice, private clinic in the south of Spain. We perform around 100 liposuctions a year and around 50 lipoabdominoplasties a year. So in combined, we get around 80 large volume liposuction procedures, which large volume I define larger than 5 liters a year. Okay. Within the last 10 years, I didn't have one case with a transfusion, and I had no death or no ICU transfer. So now the public will maybe think, what is he talking about? He's proud of not having one death, and he's proud of speaking about having no major complications, and I would never have seen this, and in my practice this won't happen, or whatever. But the truth looks different. And when you look at literature, it is not as sure as it may seem in your heads. So when you do a literature research on this, you find out that there is a high number of deaths after liposuction procedures. So these are 2 studies that you see here, which I took from the US, and they fix the death rate after the liposuction at 1 to 5,000. And 1 to 5,000 is not 0. And if you do a lot, you have to keep in account that this may happen if you don't do everything to prevent it. I took a German study, which was quite interesting. It caused a lot of trouble. This was a multi-country study done between Germany, Switzerland, and Austria. And the design of the study was interesting because it took data from the coronas, data from the intensive care centers, anonymized data from plastic surgeons and the plastic surgery societies, and they took a data collection as well from the anesthetists, because they're more neutral than we are maybe regarding complications. So they placed an ad in the magazines of the anesthetist societies. So this is an overview, just as an introduction. These were the average aspirated volumes. Even if we see 2 peaks here, which I cannot even explain how you can take out 25 liters out of a patient, but apparently you can. But in general, when you look at the volumes, the average volume was 4.5 liters. This does not even qualify as a mega liposuction from the literature definition. It's not even 5 liters. But when we look at this study, and the interesting thing is, from this study, I could really look into the metadata and really see what are the points of it. So these were patients, yes, they were big, but they were not massive obese. These patients were, yes, to part planned for ambulatory, but as well with overnight stays, and more interesting, 47 were in a clinic, private clinic setting, and 28 cases were in a hospital setting. So you cannot really put it on a non-prepared center. Anesthesia, 34 cases were done with total ITN anesthesia, and 24 were with sedation, and 17 cases were tumor sense anesthesia alone. Operating time 3.5 hours there as well. We cannot say that's too long, that's too much, that's all reasonable, but still, 75 major complications, 23 deaths. That's a big number, 4 years in Germany, Austria, Switzerland, small countries, okay? So I think we have to keep that in mind. And the study base data, perforation 9 cases, embolia DVT 8 cases, necrotizing fasciitis 14 cases. Don't forget about this. This was the most common cause of death. And I had, in the university hospital in Germany, where I worked, I had 1 case which I could see. And those cases you never forget anymore, okay? These cases are looking like a 3rd-degree burned patient, and which you treat in the same way. And this is not salvageable anymore when this happens. Necrosis 10 cases, sepsis, acute blood loss, hematoma 7 cases. So, mega liposuction or great liposuction, is it safe? It's definitely not safe if we don't do it right. So what can we do? What do we have to consider to do it right? What is the cause for this? Larger procedure times, yes. Large internal wound surface, especially when we regard infection. We have volume shifts and we have fluid electrolyte imbalances, which are very important from the anesthesia side. We have an accentuated blood loss, which we may not see, because we as a surgeons look at our fat and we say it looks yellow, there's no blood with it, but there's a lot of remaining blood loss which is in the tissue which you don't see. Lidocaine toxicity levels are very important. Hypothermia, the risk for DVT, like we heard in the talk of Jorge before, so I won't go into this, and the pain management. Now, what is the challenge to do all this or to cover all this in a private clinic setting like my home setting? Look, in most cases you don't know if I have a full ICU backup. I've got a medium recovery care. I have an intensive care anesthetist who can stay over if there's a problem, and evidently we have the equipment to do it, but it's not an hospital ICU with all the background running. You may have a possibility delay. Our lab is 24 hours, but it's not in-house. The probe needs to go there. It needs to come back. I need to access this on the computer. Diagnostic resources are limited. I don't have an angioscan, very simply said. And many of those cases are planned in an ambulatory setting. There's no multi-specialty backup. You cannot call the vascular surgeon after you basically, or you can, but it may be taking too long. And there may be organizational restrictions. I mean, my clinic stays open mostly 24 hours, but the point is, in a weekend, you do an operation on a Friday, and this patient is just not ready to get home. You need to reconsider how do you organize your nursing staff, your hospital staff, to be open on a Saturday, yeah, or on a Sunday or whatever. So all those factors play a role in this challenge. What is a large volume liposuction? Definition is not strict, mostly over 5 liters in literature. And the most adequate, that's important to see the total loss, the total volume removed, the fat and the wetting solution, okay? For me, paramount is the surgical team qualification to do the SACE. The surgeon must be used to do this. The anesthetist must be used to do this. The nursing team must be used to do this, and it's a working together. And if you don't have an anesthetist who's fit in this, I think we saw this in Jorge's talks, all the things you have to consider from the anesthetist side, you should maybe not do this in your setting. And evidently you should have as well, the environment of your private clinic facility should be adapted, should be accredited. You must have at least the access to do the thing safely and have the equipment, monitoring devices. You need to offer 24-hour observation if it's necessary. If not, don't do it. And your staff needs to be trained. Your nurses who look at the patients afterwards need to be trained, not only you as a surgeon. And then patient selection is paramount, and you need to exclude patients. And it's a failure if some patients which you don't exclude, they can either make you run in serious complications, or there will be unhappy patients because the expectations are different. It's not a solution for obesity, and there are many poor cases for large volume liposuction. These are the patient selection parameters which we use in our clinic to basically screen before what we can do or what we cannot do or what we should do and should not do. So some of them are absolute, some of them are relative. This you have to work out with your anesthetist together in the way of, say, what you think is reasonable and comfortable to do within your own setting. And then patient selection, as I said, is psychological as well, okay? They need to have realistic expectations, they need to be stable psychology, and they should not be eating disorder patients, maybe not only fluffy patients. Then anesthesia considerations, very, very important. In very large volume cases, I don't do tumescent anesthesia because I have an anesthetist. I have I have the possibility to general anesthesia, so I don't take the risk to have lidocaine toxicity levels high. So I do adrenaline infiltration, but I leave the lidocaine away or do a very low dose on lidocaine when I do it. And I do general anesthesia. You need a full intraoperative monitoring. I sometimes go to meetings somewhere else where you have proud people crying about that they do 5-liter liposuctions in an office-based setting on a chair with a pulse oximeter. That's not the way to do it, definitely not. So these are big surgeries with possible big complications that we've seen it, and they need major monitoring. Very important is in this thing is the fluid consideration. You need to measure urine output. You should warm the wetting solution. It's not so important to warm the IV fluids because the impact is low, but you should warm the wetting solution. That makes a big difference. And as well, you should be prepared to treat either fluid overload or hypovolemia, and you should lower the lidocaine dose if needed. And you should stock Intralipid. Intralipid is an antidote for lidocaine toxicity. This is a drug which basically concurs with lidocaine on the receptor and can lower the chance in the case of toxicity. And you should calculate the fluid balance following the residual volume concept. What is the residual volume concept? It's a concept, a volume theory, which basically takes into account the difference between all fluids received and the output, which is saline, which you take out in the urine output. And it makes you or your anesthetist able to calculate a little bit if the patient is going to be hypovolemic or hypovolemic after the surgery. So here you can see how you do this. You basically add together, you subtract the urine output, and then the saline portion without the fat, you divide it by the volume and the preoperative body weight, and then you get to a range where you should end at the end of your surgery. Surgical consideration, you should mark the patient in a standing position. We do a full body scrub with chlorhexidine in our days as well. Prone position, if it's needed, you turn, you do the induction on the gurney, and then you turn. And we use gel pads. We have the OR at 23 degrees for the large surgeries. And we use heating system, and most important, we don't use a Blair hugger with a system which blows warm air, because you've seen large body liposuction, 80% of the body is not covered, it does not work. So we have electrical heating, which is on the, as a mattress on the OR table, like a gel pad, which heats the patients from underneath very good. We use sequential compression devices for DVT prevention, very important point. We do prophylactic single broad spectrum antibiotic, and all of those patients are ambulate on the same day after the surgery. So early ambulation, very, very important. And muscular contraction exercise. We use thermostatic acid as well in the big cases. So you can minimize the loss of blood by using thermostatic acid. Postoperative consideration, minimum 1.5 to 2 hours of monitoring in the recovery or intermediate care unit. They should, during this time, they have the sequential compression device as well in the postoperative unit, and then early ambulation, either while they stay or when they go home. They walk, they have to walk. You should monitor hemodynamics, keep the IV rates, and discharge only if there's a solid diuresis. Postoperative, you should see them. Don't let the patient go home for over the weekend and see someone next week. See them at least latest after 24 hours. You check the compression garments. You treat generalized edema in the case that it's there. You stress out the important to a patient, how important it is to walk, to move, not to sit on the sofa, and to do a pulmonary toilet with spirometer or whatever if it's needed, if the patient has pulmonary pre-eclampsia or something. In minor doubt of DVT, you start diagnostics. You can start with D-dimer, and then afterwards you do echography, which you should have in your clinic. It's not so expensive nowadays. And in the case, major complications are, like we see here, pulmonary embolus, DVT, bleeding, a hypovolemic shock. We've seen this very good in the pictures before. The drug toxicity with epinephrine or lidocaine, penetrating injury, many cases, and major infections like we've seen with the necrotizing fasciitis and skin necrosis or skin tissue loss. So minor complications which can occur and occur to everybody who operates are contour irregularities, prolonged swelling and seroma, fibrosis, scar tissue formation, minor wound healing problems, sensory changes, hyperchromia of the skin. All those things may happen to you. DAS should not happen. Pitfalls in this case. You should avoid lidocaine toxicity in the big volume cases. And you should avoid thermal injury in the case that you use ultrasound-assisted liposuction. I personally do not. I either use vibration-assisted liposuction or water jet-assisted liposuction. So I exclude this risk for this kind, but it's very well described in literature. You should avoid fluid overload. use a super wet 1-to-1 ratio instead of a tumescent solution, and you should avoid too aggressive cannulas. You can choose your cannula design. There are cannulas with very sharp holes, so-called rapid cannulas, which makes you remove a lot of fat in a quick way, but you will have much more tissue damage, you will have much more seroma, you will have much more bleeding, and definitely an outcome which is a longer recovery. You should avoid the lack of compression postoperatively. It's very important to have a compression in these big cases afterwards. Okay? In the conclusion, patient safety in large volume liposuction can be performed safely in a private center setting, and I'm doing this since 10 years. You have to set guidelines, and these guidelines have to be strict. You have to have a team which is prepared to follow these guidelines and which has a knowledge, basically, to look after these guidelines and see if the patient is either apt or not apt for the surgery. And proper patient selection is very paramount in it. And the standards, protocols, and the treatment parameters are completely different from small volume liposuction. You cannot just compare a 1 liter liposuction with a 5 liter liposuction and say it's just 5 times the volume, 5 times the time. It is not. It changes the paradigm of the way of how you have to approach this. It changes the possible complication. It changes the way how the team has to handle and treat this patient. You need to do a meticulous fluid balance with calculations. It's very necessary. And you need, as a surgeon and as a whole team, to have a good experience with a lot of smaller liposuction cases before you start to run into these cases to change somebody who's very big into somebody who's very small. Thank you very much.